Morning and welcome to this episode and subscribe my channel Pain Free Partha for YouTube videos and free downloadable slides from my website www.painfreepartha.com. Today's topic is about setting up of an arterial line and analysis of waveforms. So our institute, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth University, and our Director of E-Learning, Professor Ravi Shankar. Now, I want to declare something. I am not a big cardiac anesthetist or a big intensivist to use daily arterial lines and possibly play with them. So I am going to do only setting up of an arterial line and analysis of waveforms. The title is very clear. Okay, it gets indications, contraindications, technique, asepsis, physics. No, it is only about setup of an arterial line. No, the first setup was, see here, the hearts, and there was a plastic tube inside the carotid artery, and this fellow is, see, this is a Stephen Hales, and he measured BP like this. Now we will go to the components of the invasive arterial blood pressure monitoring. What is that? You put a line in the artery and you connect it and monitor it. That is what is called invasive arterial blood pressure. Now, what are the components? You have normal saline at 300 millimeters of mercury pressurized. You have a flow restrictor. If you have pressurized saline bottle and IV set, but it will not go like that. You have a flow restrictor and it goes only by 4 ml per hour. You have a 22 gauge or 20 gauge catheter, pressure monitoring lines, red. They are less compliant to decrease damping. You have a transducer, microprocessor, amplifier, display. This is what is the components of an invasive blood pressure monitor. Now you see invasive monitoring, there is an arterial line, you have a sample port, non-compressible PMO line, there is a transducer, this is the flush line, there is a pressure bag, and this goes to the monitor. Now this is sensed by the transducer and it goes to the monitor. You don't have to block the arteries because your saline is flushing at 4 ml per hour. Now we have to prime the pressure tubing. Flush the entire tubing with saline from the pressurized saline bag so that there are no air bubbles or air in the line. 300 millimeters of mercury pressure means the system, the flow restrictor is designed to give 4 ml per hour. Now this is another testing. So you see, this is the pressure transducer and the three-way tap, fluid filled tubing. You have a cable to the processor, and this is the pressurized saline coming here. And if you, this is the flow restrictor, and if you just remove this, the restrictor is gone. The pressurized saline will go to the arterial system. This is what is called flushing. You have a transducer which gets the arterial blood pressure, goes to the cable and to the monitor. Now, if you want to draw it in my way, okay, this is the pressurized saline. This is coming here. This is the flow restrictor. If you pull up, it will flush. Directly, it will go to the artery. Okay. Now we have a transducer like this, and this measures the pressure from here and goes into the monitor. This is the inside of the transducer. If you want to know how two tubes can connect and then radial artery will flush, all these things, if you have confusion, it is like this only. If you want to go to the physics, I will have one more slide on maths and physics of blood pressure monitoring, which I will deal with it later. What do you mean by a transducer? And one energy is converted into another energy. That is what is called a transducer. In a transducer, the arterial pressure is making a mechanical energy like this, and this goes on to convert into an electrical energy and show in the display as BP. So, but Now here it is not a transducer. It doesn't change the mechanical, but what it does is it changes the resistance. There is already a current. So it changes the resistance. The change in resistance is shown as a difference in current. That is how it is calibrated. Now, if you want to know what is our normal blood pressure is 880 millimeters of mercury. That means it is 120 above normal 760 millimeters. Our sea level is 760. Okay. Now, if you want to know the blood pressure, a person's blood pressure is 880 millimeters of mercury. No. Now, you have to make the machine understand that 760 is equal to 0. Then if 880 becomes 120. So you make the machine understand 760 is equal to 0. That is what is called zeroing. Means expose the transducer to atmosphere and tell it this is what is 0. Now what are the classical waveforms? Now you see this is the systolic phase. This is the diastolic phase which starts. And there is a dichrotic notch. And here it goes. This is the peripheral arterial runoff. This is due to the systemic vascular resistance. This dichrotic notch probably is due to the closure of the aortic valve. Okay. Now this is the anacrotic notch, and this is the dichrotic notch limb, and this is the dichrotic notch. Anacrotic limb, dichrotic limb. What do you mean by that? Okay. People say dichrotic, anacrotic. This comes down, but there is a notch and comes down like this. Now you can see there are two waves. Okay, that is why it is called dichrotic. But people believe why it should be anacrotic. First, they call this undichrotic, dichrotic and anadichrotic. Then they removed this dichrotic and said anacrotic and dichrotic. That is how it became. This is the systole and this is the diastole. Again, I am telling, this is the systolic peak pressure, systolic decline, dichrotic notch, dichrotic runoff. This is the diastolic pressure, this is the systolic pressure. Systolic pressure, diastolic pressure. The difference is pulse pressure. Now we have to make the area under the curve, and this is called MAP, mean arterial pressure. Sometimes you see systolic is same, diastolic is same. But the thing is will show us mean arterial pressure 62 and sometimes 72. That is why, because now this is the systolic. Now the curve comes and this is the diastolic. The same like, but this is widened. This area is small. This area is widened. That the mean arterial pressure is more with the same systolic and same diastolic. That is the difference because area under the curve is meant to find out the mean arterial pressure. So same systolic, same diastolic, but MAP is different here and here. You have an electrical systole, then the contraction, then the ejection, then it has to reach the transducer and the transducer should show. That is why there is a gap of this. This is the electrical systole and this is the mechanical systole. The systolic blood pressure in the posterior tibial artery was about 25 millimeters than the brachial. See here, the systolic is like this. Dorsal systolic is like this. The brachial, it is like this. See here, the dorsal pedis. It will be like this. So why it is like this? It's a lateral systolic peak, higher systole, slightly lower. Here the diastolic comes like this. So this is the aortic root pressure, the red one. This is the radial artery pressure, the blue one. See the difference. It is slowly peaking, but peaking high. The curve is like this and goes down like this. Still the diastolic may not change much. The dichrotic notch comes low down like this sometimes. Now I used to tell why this happens like this with this thing. Now, if a person goes into the weighing machine, it will show 48.5 or 50. Now, this person jumps it into that. When he jumps into the weighing machine, it will show 57. And it goes up, it will show 37. Actual, it is 50. That is what is the principle of high systolic and low diastolic. Sometimes if you go to the peripheral arteries. This is not exactly the same, but I want to tell some example to understand what is happening in the peripheral arteries. Then what is phlobostatic axis? The phlobostatic axis is located in the fourth intercostal space at the mid-anterior posterior diameter of the chest wall. This is the phlobostatic axis. Phlobo means swaying, static means same. That is what is the meaning. That possibly corresponds to the right atrium. We have to keep like that. What? You have to keep the transducer in that plane. If the transducer is 10 centimeters below the level of the heart, the BP will be 7.5 higher. Now you see, it will be like this. Sometimes the BP may be different. Here also the BP may be different. 10 degrees lateral, 20 millimeters difference. 15 degrees, 18 millimeters difference. So that is why the transducer should be at the level of the heart. Because 10 centimeter below may change 7.5 millimeter the other side in the BP. Mostly what we do is we cannot attach the transducer to the bed. By the nearby stand only we attach. We have attached the nearby stand and you are moving head down, head up and down. Table down, table up. So many things will come. But here the transducer is connected to the IV saline stand. So this is going to be stable, while this is going to be head up, head down, table down, all these things. So we need to see what is happening with regard to the phlobostatic axis and the transducer. What is resonance? Resonance is a phenomenon. So many things confusing. No, wait. I will tell everything very clearly, slowly. Resonance is a phenomenon in which an external force or frequency causes a system to oscillate at a greater amplitude. The frequency that causes the largest amount of oscillation is called resonant frequency. Now this is going like this. Now if you give an external frequency to it, the external frequency, if it is going to be the same as that, then the amplitude rises to the maximum. That is called the resonant frequency. Understand? Or I will come back again. Resonant frequency for a pulse rate may be 1 Hertz. The arterial frequency is 1 to 3 Hertz. So we need to set up at 10 to 20 Hertz. We set up our system's frequency should be around 20 Hertz. If the frequency is at 1 or 1.5 Hertz, your frequency of the arterial blood flow is 1 Hertz. Now your external frequency is also 1 Hertz. The amplitude will go up. This is what is called resonant frequency, and you will have bad BP recordings. So that is why if you have to have our system frequency at 20 Hertz.
The string. Now I'm going to vibrate this.
Now you have
Now, at a different frequency
this.
now.
So this audio is not coming
Now the
fine.
amplitude is
So
less.
you have a
Now if I
frequency
go in
of
the
this string,
frequency which is
and if you make a
resonative,
same
the amplitude will rise.
another external
Now the amplitude
frequency,
is
the
little higher
amplitude will rise. This
because
is what is
my
the meaning.
frequency
I
is
am going to
high.
Damping is a dissipation of energy during an oscillation. In other words, think like of damping like a shock absorber. Okay, the magnitude of the difference between the input pressure and transverse pressure. We have now told what is resonant frequency. Now I will tell what is damping. Now, this bus, I will tell you, this bus goes here like this. The road has got small gaps, depressions. Now, this bus has got a good shock absorber. The input pressure is not being felt by us. Here, there is an input pressure because the bus goes like this. But if you go in this van, here the input pressure will be felt by whoever is sitting there. So we don't want the damping. We want an old van like in the arterial system so that the input pressure is directly transferred to the transducer. Any difference in the input pressure, we don't want shock absorbers. So we want these old things and not big high quality buses. So this is normal, this is over damped, and this is under damped. What causes damping? There may be free wave taps, there may be air bubbles, there may be clots. There may be additional length of tubing. That is the most important problem. To connect it and increase it because we want the monitor there, we want this thing there. So additional length, kinking like this, small kink. All these will cause damping. You have already seen what happens to the systolic peak if it is damped. Now you need to have PMO lines because see here 1.7 ml is the priming volume and 1 to 2 millimeters. But if you have this extension line, it is 50 centimeter approx, 50 centimeter approx. The diameter is 3.4 and the pressure is only 65 and you have 3.4 ml, 3 to 4 ml of priming volume. So all these things will produce damping. So we need to have PMO lines. This is what we want. Now many people use 20 Venflon. This 20 Venflon has got an internal diameter of 1.1. You see the internal diameter of this nasoangiocat is less. The outer diameter is fine. Here the outer diameter is not standardized. Some company produces outer diameters different 1.8 or 1.2 or something like that. So this is not standardized. So we don't want the sheath should go like this. We don't want this. The sheath should not go like this. The sheath should be parallel. Then only our values will be normal. What is fast flush device? That's I already told. A pressurized 300 millimeter saline is coming to a flow restrictor. If you remove this, flush. Now we drop it. Now count the oscillation after the square form. We will have a square form and flushing. Now I will show you. We have a square form and flushing. This is optimally damped. Only one is there. Now this is so many are there over damped. There is nothing is there. It is 100 damped. So that is how it results of a fast flush. Now it should have only one. Okay. There may be three ways. Here, this is better than this because we have an extension line. This is not to be done like this. The pressure lines should be examined for air bubbles. You are connecting something. Yes, we need to have air bubble checking. So, you know that this is there. We can see invasive blood pressure. What will be sometimes the other uses? How to analyze the waves? Now, this is the P max. This is the PP minimum. There is a difference between the minimum and maximum of more than 30% means you have hypovolemia. Give fluids, it will come down by 13 to 14%. Then it is hypovolemia clear. So PP max and PP min. So this difference should not be 30%. You have flushed it. Now you see after flushing. Now this is because you see the lines here, same lines here. Here it becomes better. Why? Because the femoral line was kinked in the eye. So see here, after removal of kinking, it is like this. So this is the normal wave. Okay. Now we have a reduced upstroke, and this is also relatively less. Now this diastole seems to be okay, but the pulse pressure is less. Now what is this? Slow upstroke, reduced pulse pressure, reduced BP is significant of aortic stenosis. Now you see here, there is a bifid waveform, high BP, low diastole, increased pulse pressure. All these makes aortic regurgitation. So we can see aortic stenosis, aortic regurgitation. Now you can see the dichromatic notch is low and there's a sleep downstroke. This means the SVR is low. Systemic vascular resistance is low. If you have an high SVR, see the dichromatic notch is up and this is flat and this is not steep like this as low SVR. So you have a curve like this, then you are dealing with a patient with high SVR. If you are a patient with this, then we are dealing with a low SVR. Now you see this is the low SVR and this is the high SVR. Now this is a normal waveform, vasoconstricted high SVR, and this is relatively low SVR. And this curve, if it goes like this, then we think that the sepsis is coming down because the vasodilatation is coming down. And in cardiopulmonary bypass, there is an intense vasoconstriction. After bypass, you start nitroglycerin, and if the curve becomes like this, then you see your vasoconstriction and SVR decrease is becoming relatively normal after bypass. You have a low contractility and a high contractility. Now you see this is a systolic dichromatic notch. Now we have put an aortic intra-aortic balloon pump. Systole and diastole. In diastole, it compresses so that the aortic root pressure increases, the coronary supply better. In systole, it ejects, the SVR decreases so that the flow is better. So this is how it makes. Now you see here, unassisted systole. So now the curve in IABP will be like this. If you deflate and inflate, the curve will be, this is what is called IABP, augmented diastole. Age matters. Sometimes for similar patients, you have age like this, 40 like this, and 80 like this. Now, in operation, if you keep the BP and curve like this, the hemostatic flux will get destabilized. The patient will start bleeding. So we need to make the curve like this and the systolic BP to come down. So we don't want hemostatic flux to be destabilized after diatherapy. Get the curve down, get it less steeper. Yes, cardiac output touch needed, it's a separate topic. Variations in waveform during respiratory cycles reflect changes in stroke volume. There are so many algorithms we can make out. See here, invasive, minimally invasive, non-invasive, calibrated pulse wave analysis, and we get cardiac output monitoring. So what we need to know is we have to be clear in a good arterial line. For example, angiocath, which has got a parallel sheath, and the distance it goes into the arterial line. You need to have 3.5 centimeters inside the artery. 1 centimeters, 1 centimeter inside the artery may not be much useful. So get this thing into the artery. Okay, then stop it properly, no blood and all. Then what you do is 300 millimeters heparinized line, no air bubbles. Very clearly make it as a PMO line. Okay, and attach the transducer in a way that it is into the phlebostatic axis. You get down, get up, beware. So you get a monitor and analyze. In Live, analyze properly and do a setup. An invasive blood pressure monitoring, set up properly, then analyze. Thank you all. Visit me as www.painfreepartha.com for free downloadable anesthesia slides and my YouTube channel, Pain Free Partha. Follow me all my visual aids.